Thank you, Susan, Brian, Iris, Tunisia, the whole committee for having me here. My throat's a little scratchy today, a little wheezy, but we're going to get through it. And usually when I get going on these things, my energy level picks up, and hopefully it'll come through nicely. I do have some glass of water down here, so I may have to go toward that, but we'll keep moving along. Anyway, I chose this topic today because so many of you perfusionists out there are now becoming involved with ECMO. Can I see a show of hands in the audience? How many are doing ECMO or in parts of it? Goodness gracious. For those on the WebEx, it's probably about 85%, 90% of people that are involved in some form of ECMO at this point in time. So there's obviously a lot of difficulties involved with this expansion of ECMO, and we'll get into that talk in a second. Okay. Who doesn't remember Batman back in the 60s? I know the older crowd here is Bowser. This was the original Batman back in the 60s, late 60s with Adam West. It's very short, but I'll let it run through just because it brings back great memories. God, I love that. Okay, some disclosures. I do a little bit of consulting with VitalCore and Origin Biomedical, but none of that pertains to this talk necessarily. And of course, that should have been 2 times, but that's cool. So that would happen during Batman scenes. Between the scenes, that little bat would spin around and go on and move on. Well, who the hell am I? I'm just a dude. Back in Mardi Gras too. Not the dude, but just a dude, man, like the Big Lebowski. I graduated from the OSU perfusion program, did a perfusion fellowship at Emory. I worked at the Oxner Medical Center from 1984 to just last year, 2015. At that time at ECMO, there were 5 patients done before I arrived. I was co-coordinator of ECMO for many, many years. ELSO, since its origination in 1989, like Denise, my friend had said down there, Susan, the AMSEC ELSO liaison chair, ELSO device and techniques, and many presentations and articles on ECMO. So the objectives of the talk today are to kind of take a look at the ELSO registry view on the ECMO patients to this date, and with an emphasis on adult ECMO, which many of us are becoming involved with. The reasons for the explosion of adult ECMO, the cannulation cautions we're going to mention because I see mistakes being made all the time as I travel to different centers and hear talks from all over the place. And some of the institutional challenges that I even heard our next speaker talk about a little while ago in management and staffing. And then future paradigms of ECMO. Where are we going with this? What are you going to see in the next decade or so? I think it's kind of cool to look at this old Lands Edwards, one of the first ECMO circuits that I've seen set up. It was a neat device, and the oxygenator's right actually on top here, heavy duty on the priming volume, but worked well with some of the ECMO. Well, it worked as an ECMO circuit. I don't know how well it worked, how many patients survived, but it was a good circuit for its time. Dr. Kolabo and Zappo were instrumental in doing many of the pioneering studies with ECMO. Then who can forget Dr. Robert Bartlett, who's still around with us today. Dr. Bartlett in his younger days in California, and then at the University of Michigan, and then just recently at the Children's National Medical Center meeting in Colorado. I was with him and his lovely wife, Wanda. So he's not doing any surgery anymore, but he's still doing research up there, and he's just really, I consider, the grandfather of extracorporeal membrane oxygenation. This was actually one of our first circuits designs back in 1983 at the Oxner Center. So very primitive, and I showed this at many lectures back in the 80s, and it was just a very primitive small design with the silicon membrane lung there in the middle, heat exchangers. And then that was actually one of our original setups back there at Oxner in the 80s. If you note, this cart was not very stable, so you had to watch going over thresholds or you would easily tip it over. Then we have progressed onto centrifugal pumps then and different kinds of oxygenators, polymethylpentenes, and different kind of cannulation circuits. And then I think we should mention the ELSO organization, Extracorporeal Life Support Organization, which had its charter meeting in 1989. So this was back in Ann Arbor. And the reason I mention this is because if you're a center that's actually doing ECMO and you're not involved with the ELSO organization or not a member of, I think it's kind of a crime. I think we should consider this because I think that their registry has well over 45 to 50,000 some patients in it with very good data. And that and I think it behooves you as a program, an ECLS center, an ECMO center, to submit this data to ELSO because you can also extract that data and find out how we can improve our metrics, how we can improve our quality of offering this care. And ELSO has just a plethora of academic articles on its website. So I would really encourage those that aren't ELSO members to take a look at this and become involved with it and be able to utilize this registry because it's very powerful. It really is. So looking at the ELSO registry over the years, we can see that neonatal respiratory cases have actually dropped off a bit. This is back in 1987 and back up to about 2015. So we see there is a bit of a drop-off in cases. A lot of this is due to just the improved conventional care, surfactant therapy, better ventilators, better knowledge of how we can manage neonatal patients without going on ECMO. And then, of course, the pediatric patient population has just exploded in the past 10 years or so. I think ECMO programs that were originally doing just neonates and were very successful with neonates, in other words, turning a 90% failure rate into a 95% success rate, especially with like meconium aspirations or sepsis, they became more familiar with doing pediatric ECMO. And so I think many programs were starting to incorporate older children into this modality. And I also think that I know that the cardiac surgeons with more palliative or corrective surgeries were utilizing or accepting ECMO and utilizing ECMO as a modality for placing patients on bypass after their surgery that failed to wean to come off bypass, and therefore the increase in cases of cardiac as well as respiratory. Now, one of the original randomized studies was in adult ECMO by Dr. Zapol in 1979, and he actually found, we're not going to go heavy duty into this, but he actually found very little success with ECMO, 9.5% versus 8.3% with conventional. Now, I am sorry about that. I don't know how that can happen, but it does. Anyway, the study had many problems. Basically, the adults, patients essentially were stopped in 1979. The problems with the studies were the centers that were actually submitting data weren't used to doing ECMO. They weren't very experienced with it. There were very few centers, very few patients. And so, but for whatever reason at that point, it got poo-pooed. And ECMO in the adult population fell off miserably. It just didn't work, quote unquote. Okay, so the adult ECMO invasion, the acceptance by the cardiac surgeons for bridge to decisions, that was a biggie. So now where cardiac surgeons were saying at one time, well, if it doesn't, you can go ahead and staff ECMO if it doesn't interrupt my surgical caseload. How many have heard that before? Then that's fine. Well, now, if you don't have an ECMO program behind you when you're doing cardiac surgery, perhaps you're not offering the best care that care can provide to this day. There was a quick implementation for cardiac surgeons. It's a quick implementation of RV failure, especially in compromised lungs where you don't have to go to possibly a ventricular assist device, much more expensive. And then I think that cardiac surgeons became more comfortable with doing ECMO because we've learned how to develop better control of anticoagulation. And also, it's kind of nice for their stats that death doesn't always occur in the operating room. We can put them on ECMO, get them to the ICU, and the death may be in the ICU, which is a little ominous, but it's the truth. So if we look at also active ECLS centers, now these are centers that actually submit data to ELSO. So we can see that the explosion or the expansion of ECMO programs from 2006 up to the current day. Now part of this is that there could have been plenty of ECMOs being done here back in this area, but not being submitted, not having their data submitted to ELSO. But in any case, I think that as program proliferation, cardiac programs, I think has the information that ECMO does work in adults, does work in pediatrics and adults. I think more and more centers are wanting to do ECMO and keep those patients that require ECLS within their systems and not have to send them out and transfer them. Real explosion in the adult respiratory component. This is probably where you're seeing most of your ECMO being done out there in the population now that you're involved with. Part of the reasons for this was the CSER trial, which was one of the first successful randomized studies by our friend Dr. Giles Peake in London, in Glenfield actually. In Dr. Peake's study, it was a multi-center randomized controlled study, adult ECMO versus conventional ventilatory support with patients afflicted with ARDS. There were multiple investigators, and they showed a 16% benefit survival without disability in patients referred to ECMO centers over a group with conventional ventilation alone. So there was a 63% ECMO survivor versus a 47% conventional, and it may be cost effective to transfer the patients with reversible ARDS to a large ECMO center for treatment. So in England, they had this type of spoke and hub situation where they had certain designated ECMO centers, and if that patient was out there and met the criteria and fell into that subset of patients that would be offered ECMO, they would then be transferred to an experienced ECMO center, and I think that's where you probably saw the improved results with adult ECMO at that time. And obviously this was a big study that obviously has its critics. What study doesn't? But it really showed that possibly there, with the new technology and new techniques, there isn't a way to improve and to have success in this realm. I think another huge event that occurred worldwide was obviously the H1N1 outbreak, which obviously required ECMO on many patients. You can see that we were actually fairly fortunate in North America that most of the cases, the outbreaks, were in South America and over in Europe. So we were able to develop the vaccine by the time the virus was moving over into North America. But at that time, we were learning a whole lot about what ECMO and ECLS could do with the H1N1 virus. And in fact, ELSO took the initiative with our worldwide network to grab some of these numbers in a quick database registry and look at some of the outcomes. And we could see that out of 323 patients in this early study back in 2011, 196 actually lived that were on ECMO, 106 died. And so there was some success with this, actually pretty good success, because most of these patients probably had about a 85 to 89% death chance, mortality rate without ECLS. So we could see that ECMO was working with H1N1, but there was a huge scare about what the heck are we going to do in the U.S. If this pandemic visits our shores. There's just not enough ECMO machines, there's not enough staffing, there's not enough equipment out there. So there was a lot of panic at the time, and a lot of hospitals, probably many hospitals that you were involved with, had meetings upon meetings to find out what are we going to do, and luckily the vaccine came through. We did have our share of patients, but we didn't have the same kind of situation that they had in Europe, where they actually had to shut down elective surgeries just because everybody was on ECMO, all the ventilators were being used, all the rooms were being populated, so they actually shut down hospitals just to put patients on ECMO. And we actually had some machines and devices that were sent over to Europe from the U.S. to help with this situation. So it was a real wake-up call. And I just think that because we conquered H1N1 doesn't mean that the next one's is just around the corner. We know that. So we have to have contingency plans for these kind of outbreaks where respiratory distress is going to be a severe symptomology, and ECLS may be the last-ditch effort to save our patient population. So we need to keep continuing thinking about that. The other reason for expansion is at one point in ECMO, I've been involved since '83, we just had a lot of the other medical organizations out there just really poo-pooed it. They didn't want to hear about it. They didn't want to have it in their meetings. It was all taboo and everything else. And I think they accepted that myth of the adults, it doesn't work and all that from the past. But now, many of these societies that once disapproved of ECMO are now practically begging ELSO to give talks, to give lectures at their meetings. And if ELSO doesn't have the time, then they're actually trying to put on their own talks and their own lectures to it. So there's a huge acceptance by the physician organizations on ECMO, the acceptance of it, and that's also the reason for why this increase in expansion of usage. So, institutional experience, possible paradigms. Let's say we're a small center. We put our first patient on ECMO. It's usually a last-ditch effort. There's very little interest in ELSO suggested criteria. So it's a high risk, high mortality, morbidity. But I've heard ECMO works. So, the little resident comes in. I've heard it works. Let's try to put them on. We have some disposables for it. And there's minimal anticoagulation involved, partial flow, cannulation techniques that are all kind of unfamiliar to the center. So either a disaster and subsequent long or short run with terrible experience, or a possible success with many complications occurs. If it's the first one, then there's a blame game. Well, what went wrong? Did we not have the right equipment, or was it the perfusionist, or was it the doctor, or was it the nurse, or what? The blood bank didn't have enough blood, whatever. And this is all personal experience of what I see and what I hear out there when I field these phone calls. Also, in number one, then the realization of perhaps this is not as easy as we thought. It's not just putting a patient on an oxygenator and that's it and walking away. So that realization comes to be. And then, okay, so what do we do next time? In the other scenario with the possible success, the team feels pretty good about themselves, but they worry about when and where the next one's going to be, and then what are we going to do? And because we've had one success, that more patients are going to be offered that care probably at that center because you've had success. And again, if a study of the criteria isn't made on which patients to put on, there can be further disasters down the line of patients that probably should have been contraindicated. And then, of course, the big topic that we talked about down here, staffing complications, which we'll go into in a little bit. And then, obviously, at that point, then it breeds many, many management discussions, more meetings. That's what we want, more meetings in management. So, what do we do next time, and what have we done, and what can we learn? Okay, do we avoid ECMO and ECLS altogether? Do we do immediate transport out? And of course, these days, administrations do not want to do that, right? They want to kind of most administrations kind of want to keep those patients within the system because they feel if they put those patients out there, they'll lose that within the systems. Now, I'm talking about the bean counters, not the clinical care providers. Now, if you're a system and you have a center that does ECMO, maybe that's okay. But if you're sending it outside of your system and you may not get that patient back, many administrators disapprove of that kind of thinking, and they'll probably push you to do ECMO within your own hospital. So what the paradigm usually is, calls are made to learn ECMO, money is spent, travel to different centers, hire trainers to train, and contract out to have a course brought into the hospital that wants to do ECMO at that time. So just a little bit about the adult diagnosis and survival. I'm not going to go heavily into this, but you see these days we're more into the 50 to 60% survival. This other is a very generic column. We won't go into why that is because some of these are hard to completely have a specific diagnosis. But once we were looking at less than 25, 30% survival, now it's up to 60 and 70% with some of the better centers. And of course, there's many equipment improvements that are out there from the days of old. And unfortunately, we're still battling our FDA in the U.S. here on trying to get some of these products in here on a quicker basis. I know I'm very involved with that. They are definitely liable, and we're a litigious society, so I understand their point of view to a certain degree. But on the other hand, there's many products that other countries and parts of the world have that we don't have, and it would be nice to expedite this with a little bit greater concern than they have so far. They have changed the classifications within the FDA on ECMO equipments from classification 3 to 2, which helps, but it's not enough. So we continue to push to try to get newer equipment in and have competition stiffen so that we can have better products in this country. So in veno bypass, I think part of the cannulation techniques, we either have the two-site cannulation, where the femoral vein is cannulated and pulled from the femoral vein, and a long extended cannula up to around the right atrial right atrium. Sorry, and then we return blood back into through the cephalad area into the right atrium and provide veno-venal blood there. Or we have the single-stage cannula, which helps to make our patients nice and ambulatory. It's nothing nicer than having an ambulatory VV patient that may be waiting for a lung transplant. They're extubated, they can get up, they can strengthen themselves, they can have exercise, their mood is better. I mean, it just reminds me of the days of the ventricular assist device patients when we could actually put a old pneumatic heartmate vat into them, and they're laying in bed for 6 months, all of a sudden they're getting up and they're exercising and moving around, and boy, when they have that transplant, they're up and at them at no time at all. So phenomenal to have ambulatory ECMO at this time coming of age. If we look at some of the respiratory, the VV components, we still see, though, that most centers are doing the two-site veno-venal cannulation with a smaller using the dual-lumen veno-venal cannula. So I believe this part of the pie will grow, and this will start decreasing. There are some people that are against this that don't feel like they're getting enough flow with the dual-lumen veno-venal cannula. But if we remember, when we're doing veno-venal bypass, we don't need to have optimal VA flow. We just need to have partial flow, and we just need to have about an 80% saturation on pulse ox to have a patient that's going to do well in a good environment. So we don't need to push the flow like we do on VA ECMO. So I think that the VV dual lumen, once the knowledge is there and the practice is there, will be very helpful to us, and I think that part of the pie will grow. In the veno-arterial, then, we have the transcervical approach, the femoral approach, which is good for emergencies. We'll show that in a second. And of course, the transthoracic, that if you're a cardiac patient that hasn't come off bypass and you want to stay on ECMO, why put new cannulas in? Why not just keep those nice arterial and venous cannulas in the chest? And they actually have preferred flow, and patients do quite well with that. The results show that patients with central cannulation do remarkably well in the post-op period if their heart has a chance to survival. And then we have the axillary subclavian. So for those of us that don't have to emergently put on ECMO, we can put a graft into the subclavian, put an arterial cannula into that graft, and the advantage of this is then we have antegrade flow rather than the retrograde flow, which we get with femoral cannulation. So again, with femoral cannulation, it's quick and it's emergent. I think what most programs do at this point in time, prophylactically, not just if you have pulses distally, is they will add an arm off the return cannula and allow the blood to shunt around and perfuse distal to the leg. So I think that's very important in keeping the perfusion to distal to the leg in case blood flow has been compromised distal because of the cannula being in the vessel itself. Okay, so I think this is a really important point here. When we're on fem-fem cannula, and I see this mistake being done all the time, but I think we're getting smarter and smarter at it. We have two different circulations occurring. We have, in VA, fem-fem ECMO, we have the ECMO circulation, and of course we have the anatomical circulation occurring up at the top. So we have blood that's going through the heart, because we're only on partial bypass, and blood that's going into the bottom part of the body. There's mixing of blood that occurs somewhere in the aorta. So you have a competition of blood flow that's coming up from the ECMO circuit and being ejected from the heart. And somewhere in the aorta there's some mixing going on. Now that is dependent on how well the LV is contracting or LV function. And so there is some kind of ratio of ECMO flow to LV ejection. So if the LV blood is poor because the lungs have been compromised, so there's oxygenation in pulmonary compromise, so the left ventricular output, now the blood is deoxygenated and poor. Well, what do you think happens? Well, we get hypoxic blood now that is being perfused to the proximal aortic branches, or the great arches, while the lower body perfusion is being perfused very, very well, nice and pink. So you have blue up here and you have pink down here. So obviously the sacrificed organs is going to be at this point the brain, the coronary arteries, which obviously the heart needs to function well, is going to be receiving that desaturated blood. So the blood sampling is hugely important for this kind of ECMO. So if we're doing femoral cannulation, femoral blood draws back here down on the lower body, we may see beautiful O2 saturation, but is that necessarily what we're seeing up at the top of the head? Not with compromised lungs, no. We may see 200 PO2, but the head itself may be 40, 30, because it's, again, poor desaturated blood coming in from the left ventricle through compromised lungs and going to the head. If we looked at the left radial, again, it could be O2 saturations could be nice and high because it's coming off that left subclavian. It could be indicative of the perfusion flow, but not necessarily of the left ventricular output. So therefore, right radial assessment is probably more important, and pulse oximetry on the right side, the right ear and the right finger, that more fully reflects what the brain may be getting. So possible solutions for that is to either increase the ECMO flow, which also, now we're limited to the venous return, but increase the ECMO flow, which increases that ratio of ECMO to left ventricular outflow. So if we increase the ECMO flow, we're increasing oxygenated blood and taking away from some of that desaturated blood. Adjust the ventilator. The ventilator doesn't have to be on complete apneic settings. If we're having that issue, let's go ahead up on the ventilator a little bit, the settings, and let's go ahead and optimize, without hurting the lungs, some of this desaturated blood so we don't have further injury. And at some point, though, if we're really hurting, we may want to consider, we're on bypass, we may want to consider the axillary cannulation for antegrade flow in the aorta that would then provide that oxygenated blood to the great arteries and to the brain. Okay, so some of the other institutional challenges: who's in charge? All our team members on the same wavelength. Physicians must communicate on the strategy well before the first ECMO, if possible. So I had a slide before that. I might have skipped over that. How many times have we been on ECMO in the ICU, and they have all kinds of different intensivists that come in to tell us about what we can do with our ECMO. The pulmonologist comes in, the hematologist comes in, the cardiac surgeon comes in, and everybody tinkers a little bit. We've got to be on the same page. You've got to have a hospital that they all get together and somebody's in charge, and that's so important. I see such confusion and such frustration on the ECMO specialists when that's not done. So when we look at staffing needs, we should look at, when we're looking at administration, it's not the number of ECMOs we're doing, but the ECMO days that we're involved. The length of time of ECMO can be 3 to 5 weeks on the adults. There are two-person care providers, single care providers, and hybrid approach, which we're going to go into. The two-person care provider, as I think what most of us have been used to, we've had a primary nurse, and we've had a respiratory therapist taking care, and we've had a specialist at the ECMO bedside. Give me a little cheat sheet here. How are we doing on time? I forgot my phone. I know it's still green. Okay. Okay, and then a new concept that's come up pretty much, and a lot of centers are now incorporating, is the single care provider, where the primary nurse is actually very well trained in ECLS ECMO. Now, these are patients that are actually quite a bit stable. They're not bleeding heavily, and they're on a type of device that maybe has some servo regulation that can alarm or that can slow down if there's issues. There's other ECMO people trained nearby. So for the smaller centers, it can be a problem, though, because they're low-volume centers. It's difficult to maintain competence. There is a fear factor, and it results in general dismal results. Extra staffing issues, 24/7 cuts into staffing of any department. So this is a 24/7 care, so if we can cut down and try to not have the two care providers, that helps with the staffing usages. And then some of these smaller centers are having to contract out ECMO services, which I do occasionally, which it can be pricey and cannot assure competency. So I looked at a couple of different centers for those of you that are looking at different ways of staffing centers, and we look at 5 different ones that have used hybrid approaches. At the University of Alabama here, they have actually a little area that they do all their ECMOs within. It's like a big old room. And they have, if there's less than 4 patients on ECMO within this one room, there's no walls, they have one specialist and a perfusionist involved just with the ECMO. Now, they have several nurses that are caring for the patients, but one perfusionist and one specialist that are caring for all 4 ECMOs at the time. If they have 7 patients, then they then they may have 2 specialists and a perfusionist, but they always have a perfusionist in-house at the UAB center. Now, at the University of Maryland, there's 2 different units on the same floor. They have 4 full-time respiratory therapists and a pool of respiratory therapists and perfusionists to pull from at that time. But again, they have 2 different locations, but they're relatively centralized locations, so they can have staff. They're on the same floor. They can move back and forth. So it's kind of a roving type of staffing model. At Duke, the RT specialist covers up to 6 patients. Nurses are well trained, though, and to spot issues. And if there's greater than 6 patients, another RT is added, and perfusion is always around at Duke to help with their situation. So you have multiple helps, but again, another situation where you have multiple ECMOs going on with 1 trained specialist and some backup behind them. Columbia, in-house perfusionist all the time. All nurses, they do very strict online video sessions. They have a spectrum medical system so that a central location, a perfusionist, or somebody that's a very specialized charge nurse can watch all the ECMO patients on a screen in a centralized room, and that helps them with their staffing needs. And then at the University of Michigan, they take primary care providers to the full extent. They provide very specialized training, and there's often two nurses per patient, but they're both, all nurses are very much ECMO trained. Then they have a roving nurse or specialist and a perfusionist that can also help in dire situations. So those are a couple different hybrid models.
Gives a feller a good feeling to know they're up there doing their job.
Okay, the reason I bring up that little cartoon there from Batman back in the 60s was that there are a number of programs now around the country, some notably in the Northeast, where they are actually using a spoken hub type of organization where they do have an ECMO center that is considered one of the top or one of the fully equipped ECMO centers. Now they can put their patients on ECMO, say on a cardio help or so, at some of the outlying centers, and then have those patients brought into the main center where they may have the room for them, the space for them. They may have different equipment. They may have different specialists on board. I think eventually we probably will have to go to that in this country, but I know it's going to be slow process, and I know that at this point we're not going in that direction necessarily, because I think more and more individual centers are now still saying, well, let's go ahead and have ECMO in our center rather than sending them out. But it is very costly. It is very labor intensive. And I think that as ECMO becomes more and more accepted for patients that are that have different diagnoses, I don't know if we'll be able to handle the loads out there in our small centers. So there will have to be transportation out to other centers. So I think, though, like the European model, we do have to keep note of that spoken hub type situation, especially in our community hospitals, especially if you're a system like in the Oxner system down there, where you can put an ECMO patient on one of their satellite hospitals, put them on in that center, bring them in, and then care for them in the mothership, if you would. So institutional challenges, of course, transport is a whole other game that people have to overcome when they talk about transport. Again, labor intensive, pretty tough. You have to have the right aircraft. You have to have the right equipment. Okay, so this is a really interesting topic, and as we're concluding the talk then, mechanical ventilation. What are the negative impacts of just mechanical ventilation without ECMO? We know there's barotrauma, oxygen toxicity, hemodynamic compromise, weakened diaphragm muscles, increased dependency on ventilator, ventilator-induced pneumonias that occur. We know that the ET tube, requires sedation and analgesic usage. Patients are unable to speak, feed, or engage in any helpful physical activity, and so there's obviously reduced quality of life. We do know that in ECMO, then, we can go ahead and turn the ventilators down to a low volume, low pressure settings, especially in ECOR, where we're trying to remove carbon dioxide for acute lung injury, acute respiratory distress syndrome, COPD patients, influenza outbreaks like the H1N1, and other non-ARDS types of complications. So we do see and then eliminating long-term mechanical ventilation effects is important to us, especially in patients that may be on ECLS for long-term pre-lung transplant because of the associated lung injury and associated pneumonias and the other type of problems that we can see here. So, with the paradigm that's going to now, that some of you may already be involved with, is we have three different scenarios on a patient that has respiratory failure in column A, column B, and column C. So our traditional category has been column A, where they're on mechanical ventilation. They're possibly failing that. Maybe they've blown a pneumothorax, or maybe the lungs, you've just been on a long time and the lungs are getting worse, and the patient's going downhill. So we add ECMO to it with IMV, and then we come off ECMO, hopefully successful. We stay on IMV for who knows how long, and then we wean off mechanical ventilation. The new paradigm that we are now going to, patients that are with respiratory disease, is having done them on, of course, they're on mechanical ventilation initially. We are then, we may include ECMO into that if we failed with mechanical ventilation, and then we want to go ahead and take mechanical ventilation away and remain on ECMO like you see on our VV patients, our dual lumen VV patients, or even our two-site VV patients. So now that we have a patient that can now talk, they can now eat, they don't have the problems associated with mechanical ventilation, but they're on ECMO alone. They can sit up, and then hopefully we can wean off ECMO. This is the paradigm that's going to become more and more commonplace out there. It's a slow go, but you're going to see it more and more out there. Or we go on to ECMO alone. We never even worry about intubation. We either wean off ECMO, or then we go to bridge to decision or bridge to transplant. So the idea with the new paradigm then is to get away from mechanical ventilation, pull the ET tube out, and let that patient have a quality life and strengthen themselves and do all that we do naturally as human beings, and possibly breathing on their own as well, and stay off the muscle relaxers, and I think we'll have a stronger patient. And I think the success up in different centers is really showing that there is an improvement with this kind of care, but we'll be moving in that direction. Areas of opportunity, U.S. mortality 2013. Look at all the patients under chronic, all the patients that have the different influenza, pneumonia, influenza, septicemia, all the different patients that's possibly out there, 8,000, 3,000, 6,000, 38,000. So there's tons of patients that probably are out there that could benefit from ECLS. ECLS hypercapnic respiratory therapy could become as widespread as continuous VV hemodialysis. So again, with some of the recent equipment that that has been coming out there, I think that's the direction we are going these days, and there's no reason why perfusionists shouldn't be involved in at least a teaching or a hands-on or a looking at the new equipment approach. And the merger of the technologies continues, where you have the oxygenators and the pump systems that are merging, kind of like the CardioHelp, and more systems that you'll be seeing within the next year, year and a half. The future is a small circuit. Small, like a ventilator. Sorry, I don't know what happened here. Analogous to a smaller ventilator. High volume usage, so instead of the ventilator, you'll have this type of ECLS device, invasive. Efficient gas exchange, pump or pumpless. Minimal to no thrombosis, portable and small, self-powered, internal pump units, servo-regulated pressure, venous saturation, O2. I mean, all these things are going to be incorporated into this type of circuit. So instead of the ventilator, you'll be seeing this type of ECLS device next to the patient's bed. You see the number of ELSO programs now that's gone worldwide. It's really expanded. So this registry now is so intense because we can now grab information from Europe and from Asia before we even see this type of patient in North America. So it's really been a nice expansion and a great deal of information coming our way. and then several of the different ELSO-type centers that have originated in different parts of the world. This is a position paper that many of you might want to take a look at either on the ELSO website or get a hold of. I was part of this paper, a position paper for the Organization of Extracorporeal Membrane Oxygenation Programs for Acute Respiratory Failure in Adult Patients. So it's a good read. Again, you can find it on the ELSO website. The author, main author, Alan Combs. And then I had to add this last cartoon before we leave here, so let's see if we can make this leave. Now, how do we...
Look, here it comes now. Now, how in the world did you manage that?
There's no time for that now, Batgirl. To the alley. I'm afraid I'll have to put you to sleep until we reach the city, Batgirl.
To sleep?
So you won't learn the location of the Batcave.
All right, Batman.
Guard your face, Rabbit.
You know something, Batman?
What's that, Rabbit?
She looks very pretty when she's asleep.
I thought you might eventually notice that. That single statement indicates to me the first oncoming thrust of manhood, old chum.
Thank you, Batman, for that advice. Thank you all very much for your attention.